Okay, welcome everybody to this last webinar as part of the Partners in Care National Safeguarding Adults Week events. And I'd like to welcome today Debbie Foss, who is a PhD candidate from the School of Law at Keele University. And Debbie is going to talk to us about a thematic analysis of safeguarding adults reviews and domestic homicide reviews. And great news is Debbie is sharing with us an article that she's just had published in the Journal of Adult Protection after today as well. Thank you, Debbie, and over to you.
Thanks very much, Karen. Okay, well, let's hope we can get to the first slide. Yeah, that looks okay. So under Section 44 of the Care Act 2014, Safeguarding Adults Boards, commonly known as SABs in England, are responsible for commissioning safeguarding adult reviews, which we'll refer to as SARs. The purpose of the SAR is set out in the Care and Support Statutory Guidance. If you're interested in exactly where that is, it's Chapter 14, Section 164, and the aim of a SAR is not to apportion blame, it's all about learning. So the aim is to promote learning and to prevent serious harm or death from occurring in the future. Safeguarding Adults Boards are required to commission SARs where an adult with care and support needs has died, or where an adult is alive but they've experienced serious abuse or neglect, and there's reasonable cause for concern regarding how the Safeguarding Adults Board, its members and other agencies, so that could be adult social care, fire and rescue, health colleagues, police, how other agencies work together to safeguard that adult. There might be other situations where a safeguarding adults decides to commission a SAR involving an adult in its area with care and support needs, but whether or not the local authority has been meeting those needs. And that's set out at Section 44.4 of the Care Act. So examples of that would be a near miss incident, so where the individual could have died but they didn't because of the intervention. In 2017, which feels quite a long way away now because it was pre-COVID, there was an independent review of the Mental Health Act 1983, which was announced by the government. And the purpose of that review was to consider how legislation in the Mental Health Act is used and how practice might be improved. It's a long time ago since the Mental Health Act was enshrined into law, 1983, so over 30 years ago, 40 years in fact, and it's unsurprising because it was so long ago that the Mental Health Act is now really out of step with other bits of legislation that have come since. So examples are those key characteristics of adult safeguarding legislation, such as the drive towards greater personalisation and respecting the views of the person experiencing abuse. So prior to the Care Act, people were sort of done too, really, in terms of safeguarding, but with making safeguarding personal that's come in with the Care Act, it's much more about what that person wants and all about that personalisation, which I think is exactly how it should be, that we're keeping individuals at the heart of the safeguarding process. The final report of the independent review of the Mental Health Act concluded that the Mental Health Act doesn't always function as it should, so perhaps not surprising because it is quite old legislation now. The review found that disproportionate numbers of adults from Black and minority ethnic groups were being detained under the Mental Health Act, and that current processes were not consistent with a contemporary mental health care system. So the care has moved on, but the legislation hasn't. It's stuck 40 years ago. The fact that the government is proposing to reform legislation via review of the Mental Health Act supports the view that mental health law is an area of practice which has faced challenges. The proposals aim to put people at the centre of decision-making, which aligns with the Care Act principle of personalisation. I must say, actually, that I undertook this research a little while ago, and since then, really this presentation and the research is a bit historic, because we've not heard any more about that independent review of the Mental Health Act. So that is really at a standstill. We don't know if it's still going to go ahead, or there's not really been any progress on that. So we'll bear that in mind as we go through the presentation. So I analysed a large number of safeguarding adult review reports on a national basis for my research, and these were sort of the main messages coming out of that, that despite the fact that there is quite a lot of research analysing reports from SARS, there's minimal data on the application of mental health law concerning safeguarding adult reviews. So it was a fresh topic really to look at. And the aim of this research was to investigate the following 4 things. These were the overarching aims. What extent is adherence to the Mental Health Act important in the context of adult safeguarding, and why is it important? Looking at the role of the Mental Health Act in safeguarding adults at risk of abuse and neglect, so under that Care Act definition. Looking at how well the Mental Health Act is understood by practitioners that are working with adults at risk of abuse and neglect, and that's on a multi-agency basis. And then to what extent does use of the Mental Health Act by practitioners need to be improved? If it does need to be improved, how might that be achieved? So I'll talk a little bit about the research that I've done. The existing research literature on SARS and on adult practice reviews, which are undertaken in Wales because the legislation is slightly different there. The existing literature tends to be generalised rather than a specific focus on the Mental Health Act 1983, which is why I decided to focus on that for my research. And the existing literature is really primarily focused on a lack of legal literacy amongst professionals. So there's some really good information out there. I'm sure a number of you will have heard of Professor Michael Preston-Shute, who's undertaken a large number of safeguarding adult reviews and has done some absolutely cracking literature reviews and large-scale reviews with a real focus on self-neglect. Martineau and Al, they undertook some research in 2019, and then Manthorpe and Martineau in 2020, so a bit more recently, and Manson in 2017 undertook a review of SARS from the Southwest region. Preston-Shute really found that there was a repetition of review recommendations, and there were failings in reporting abuse into safeguarding procedures. And we know that we've already said earlier in the presentation, an overarching aim of the safeguarding adult reviews is to promote learning and to improve practice. There was some research undertaken by a chap called Jay Aylett a few years ago now. I think it was perhaps about 2014, and he emphasised the potential of reviews as national learning resources. Now, his research was pre-Care Act, so he undertook a thematic analysis of serious case reviews, which were the forerunner to safeguarding adult reviews, and he looked at 114 serious case reviews. The overarching theme coming out from that research was the aim to standardise learning for adult safeguarding practice. And in over 60% of that sample of 114 reviews, the individual was recorded as having a mental health disorder, with a formal diagnosis in 30% of those cases. So it's really relevant to this research, even though it is pre-Care Act. The numbers were significant when considered in the context of wider research, which evidences underreporting of safeguarding in mental health services prior to the implementation of the Care Act. And that was some research undertaken by Williams and Keating back in 2000. So that's over 20 years ago now, but the messages from that are still relevant to today. Research undertaken after that 2000 research evidences that adult safeguarding continues to be underrepresented in mental health care. And although that research undertaken by J. Aylett considered safeguarding reviews which were published prior to the Care Act, those findings still remain relevant because there are parallels with later research. Included in that, 134 recommendations for strengthening practitioner training and practitioner competence. Research into lived experience, which I really think is absolutely crucial, that we are looking at lived experiences of people. I think that is pivotal, and it absolutely links into the concepts of personalisation and making safeguarding personal. And that found, looking at lived experience, a lack of mental health representation within adult safeguarding forums. And this is more recent research. So Hafford Letchfield, they looked at some research in 2020 and concluded that arguably that had resulted in insufficient implementation of safeguarding policy in the context of mental health provision. That echoed the findings of Manthorpe and Martineau's study of SARS, which they undertook in 2019, which suggests that standardising practice in the context of reform of the Mental Health Act needs to consider the interface between mental health legislation and the Care Act. So even though we're not sure at this point what's happening with that Mental Health Act reform, these are still important messages that I feel really need to be acted on. The Care Act would apply in those cases because many people that are subject to safeguarding adult reviews have care and support needs under Part 1 of the Care Act 2014. The Mental Health Act Code of Practice states that the Care Act duty for professionals to work collaboratively to provide person-centred support is absolutely fundamental, and even more so for people with mental illness. So back to Manthorpe and Martineau again, observations that they made in respect of Mental Health Act assessments had been highlighted in earlier studies, specifically regarding a lack of multi-agency working and the care programme approach that's used in mental health care, those care programme approach practices not being aligned with the inclusion criteria which is specified in the national guidance. Continued inconsistent application of mental health law evidences that legislation is not well understood by practitioners who are working with adults at risk, and use of mental health law by practitioners requires improvement as a result. A review of literature regarding safeguarding adult reviews, again, these were two 2017 reviews that were undertaken by Professor Michael Preston-Shute. That literature review affirmed that health, care and support providers are not always clear regarding their responsibilities to report safeguarding or to make referrals. And that research in 2017 is 3 years after the Care Act. So that might account for the underrepresentation of adult safeguarding in mental health services, which Hafford Letchfield had identified in 2020. Since 2014, the Care and Support statutory guidance has required all service providers to have policies for reporting safeguarding to the local authority. That's again at Chapter 14, Section 52. Implementation of escalation policies or promoting a positive culture of reporting those safeguarding concerns would partly mitigate risks of non-reporting, but notwithstanding that cooperation in specific cases is a duty under Section 7 of the Care Act. Thematic analysis of reviews identifies various commonalities. So these include a lack of coordinated information sharing and collaborative working across and between agencies. Generalising really from looking at the reviews, had cooperation between agencies been better in cases where this had been identified, that might have led to more timely identification of and response to abuse or neglect. Preston-Shute again noted that review recommendations are not limited to the area where the Safeguarding Adults review took place. as review recommendations and findings are typically repeated. So we're still seeing today the same messages that we were seeing from the very first safeguarding adult reviews. I think we've got to ask ourselves what lessons are really being learnt from safeguarding adult reviews, because we keep seeing the same things: lack of professional curiosity, information sharing could be better, they're consistently being repeated. When I undertook this research, there was no current complete central repository for safeguarding adult review reports or for the adult practice review reports, which are undertaken in Wales. Now, I know Professor Michael Preston-Shute has worked with the local government association, and there's a sort of chair of safeguarding adult boards group for all the independent chairs, which is a national group. They've worked together to set up a repository for SAR reports. It is pretty good, actually. I think the start date is something like 2017, and safeguarding adults boards can upload their SAR review reports to that repository. So we're in a better position, actually, than when I undertook that research. There's also the Sky repository, which was, I think, from 2014, but there are some gaps in that, and I think Professor Preston-Shute have taken all those earlier SAR reports and put them in the national repository that he is working on. But at the time I did this research, there wasn't that repository. So what I did to source the SAR reports was to look at the local government association list of English and Welsh councils to find the relevant local authority. Perhaps not surprisingly, that list was out of date. You always do hit snags when you're undertaking research. So the information from that list was triangulated with the Office for National Statistics list of local authority districts, and that returned 337 local authorities across England and Wales. From that list, I located the relevant Safeguarding Adults Board and then the Safeguarding Adults Board websites, which were searched to identify published reports that were not available via those existing repositories. That returned over 350 reviews, so it was really quite a task. After reading those reviews and then narrowing down the results to filter just those safeguarding adult reviews where the Mental Health Act was central to the review, there was a total of 69 safeguarding adult reviews and 1 adult practice review. Each report was read to identify whether the Mental Health Act was referred to within the review commentary. And then once reports were selected for inclusion in the sample based on that reference to the Mental Health Act, they were read again to ascertain whether the Mental Health Act was central to the review. So if the review just referred to the Mental Health Act, but it hadn't actually been used or formed a substantial part of that Safeguarding Adults review, then it was discounted on that basis. There were a number of themes that emerged from those safeguarding adult reviews. So the overarching themes were that the person involved in the review had experienced an adverse childhood experience, which we commonly refer to as ACEs. That was 30% of SARS analysed. These figures don't add up to 100% because often there were multiple factors in a single review. Domestic abuse featured in 40% of reviews, substance misuse in 39%, the person having a criminal record or significant contact with the police as an offender in 30%. Self-neglect was the second highest with 51%, homelessness 20%, a reduction or a delay in service provision. So either the person's services had been reduced or there was a delay in services being provided when it was identified they were needed. That featured in 37% of reviews. And the person having difficulty engaging with services, that was a feature in 57%, the greatest. And then the person having either significant self-harm or a history of previous suicide attempts, that featured in 39%. of reviews. So adherence to the law was really the focus of my research, and these were the main themes really that were coming out of the review. So the individual's views and wishes not being considered. So we know that's really in direct contravention of the Care Act, where the person should be absolutely central to everything that's about them, including adult safeguarding inquiries. A lack of referral for or a lack of use of advocacy. So that's the instruction of an IMCA, an independent mental capacity advocate, which is at section 35 of the Mental Capacity Act 2005. A failure to plan or arrange care, most notably again under the Mental Health Act section 117, where there is the duty to arrange aftercare where the person has been subject to detention under section 3 of the Mental Health Act. The interface between the Mental Health Act and other legislation, such as the Care Act, delays or reduction in provision of services, which we've touched on. And there was a little bit of good practice. You'll be pleased to know it wasn't all negative. There was some good practice in upholding human rights. So of the SARs analysed, 91% of them, a total of 64, made multi-agency recommendations, and recommendations were most commonly directed to the Safeguarding Adults Board, followed by local authority adult social care departments and NHS trusts. Unsurprisingly, given the nature of the SARs, because they all were referenced to mental health being central, that use of the Mental Health Act, mental health trusts featured most amongst recommendations that were made to health services. Not considering individuals' views in relation to their care and support, specifically in relation to working in a person-centred way, involving the person or their family or their support network, and a lack of referral for or use of advocacy was a recurring theme. In circumstances where individuals had substantial difficulty in being involved in principal decisions concerning their care and support, including care planning, safeguarding inquiries, and safeguarding adult reviews if the individual is alive, the local authority must arrange independent advocacy to facilitate the involvement of the individual if there is nobody appropriate to support their involvement. That's set down in the Care and Support Statutory Guidance at Chapter 7, Section 42, and also in the Care Act, Sections 67 and 68. Where people lack capacity to make important decisions, such as consent to serious medical treatment or a change of accommodation, and where they've got no family or friends with whom it would be appropriate to consult, then an independent mental capacity advocate must be instructed, as we've said on the slide, under Section 35 of the Mental Capacity Act. The role of the appropriate individual, which is set out in the Care and Support Statutory Guidance under Chapter 7, that is arguably more comprehensive than the role of the person whom it's appropriate to consult, which is set out in the Mental Capacity Act Code of Practice. That's because the appropriate individual's function is to facilitate the person's involvement as opposed to consulting with them or making decisions on their behalf. A lack of consideration of individuals' views was prevalent in situations where the person's primary professional was a health professional, as opposed to individuals whose care was coordinated by the local authority, and that theme emerged in 30% of the SARs which were analysed. Common characteristics in those cases were individuals self-neglecting or experiencing difficulties engaging with services. 10 reviews featured recommendations concerning individuals and their engagement. Training for professionals was a common sub-theme, with recommendations including directing the Safeguarding Adults Board to produce and disseminate multi-agency advice on best practice with adults who don't engage or who disengage from services. And that was in the SAR Mr. B, which was undertaken by Leeds. That theme was exemplified in relation to Stacey. This was from Warrington Safeguarding Adults Board. Stacey was detained under Section 3 of the Mental Health Act when she died, and she'd been detained in hospital for 4 years. There were a number of discrepancies in professional application of the Mental Health Act. So despite being detained under Section 3, Stacey was unable to access an independent mental health advocate for 2 years as a result of cross-border disputes because she was placed out of area. The review noted that Stacey's father had rights as her nearest relative under Section 26 of the Mental Health Act. He discussed his view that challenging placements would be futile. That was his view, because his understanding was there were no alternative placements, so Stacey couldn't be placed closer to home. That highlights the importance of having access to an independent professional, because that would have enabled Stacey to understand and exercise her legal rights. Her father had rights to information regarding the independent mental health advocate service because he had that legal role as nearest relative, and he would have been able to contact an independent mental health advocate on Stacey's behalf. 3 further reviews that were analysed made recommendations directing a review of practice regarding the involvement of the nearest relative, including expectations in respect of information sharing. The review recommended that the local authority establish procedures in respect of advocacy provision to assert that advocates are routinely available where people are detained under the Mental Health Act. The review did acknowledge that cross-border placements can impact on commissioning arrangements, but suggested that the delay in Stacey accessing an independent mental health advocate was the result of poor communication between professionals. And we'd mentioned earlier, this is an overarching theme and it's repeated in recommendations from SARS. So even SARS that are being published now will have as a recommendation to improve that multi-agency communication. The research has evidenced a failure to adhere to the law regarding Section 117 aftercare, specifically entitlement to and arranging care under Section 117. Recommendations regarding Section 117 featured in 4 SARs that were reviewed. Deficiencies in TPA, the care programme approach planning, and failure to adhere to the law in respect of CPA were identified as intersecting themes, with recommendations around that in 17 SARs. That was more common in complex situations where the person experienced difficulty engaging with services. So as we've said, if somebody's experiencing difficulty and they've not got a relevant representative, they should be referred for advocacy. And also in situations where the person that was experiencing difficulty engaging was self-neglecting. There were 33 cases where the person displayed self-harming behaviours, and 27 of those involved suicide attempts. So analogous with the lack of referral for advocacy, that was prevalent in cases where the person's care had been coordinated by a health professional. So looking at another case, William, this was a SAR undertaken by Sandwell Safeguarding Adult Board. He experienced several hospital admissions and detentions under Sections 2 and 3 of the Mental Health Act and was subject to CPA. His residential care was funded by Section 117, and from the outset, William exhibited challenging behaviour, which culminated in assaulting another resident. As a result, the care home had asked for William to be moved. At that point, he was admitted to hospital under Section 2 of the Mental Health Act because there was no alternative placement available to meet his needs. The Mental Health Act assessment was delayed because of a lack of professional understanding regarding local processes. So again, we're back to that theme of the information sharing and the joined up working. And there was a lack of clarity regarding roles, responsibilities and pathways for patient care. And there's a person at the heart of this. So, you know, none of this is doing William any good. Professional practice diverged from the Mental Health Act Code of Practice, as prior to William's discharge from hospital, professionals should plan aftercare under the CPA. Divergence from the Code of Practice was evidenced in a further 7 reviews. As that planning hadn't happened, it was not known who the lead agency was for William's care once he was discharged. The Code of Practice states that the care coordinator must be fully involved in decision making at section 14, and any decision to depart from the directions of the Code of Practice must be justified. And I would say they must be recorded somewhere, which they weren't in this case. That had been overlooked. We know William was subject to section 117 of the Mental Health Act, so there should have been no disagreement between agencies regarding how the alternative placement was funded. That should have been absolutely clear. And it's incomprehensible, really, why that funding didn't transfer to the new placement. In contradiction, there were attempts to undertake a continuing healthcare assessment, which represents further failings because section 117 takes precedence, which was in the National Framework for NHS Continuing Healthcare. That framework evidences that the local authority and the clinical commissioning group, which we had at the time of that review, now integrated care boards, they failed to adhere to the law regarding their duties under the section 117. The CCG wasn't involved in searching for a placement, despite the fact that they'd got knowledge of specialist placements, and it was their duty under section 117 to arrange the aftercare services. It's an NHS responsibility to fund health services, and specialist health placements were considered as part of William's discharge planning. As a result, the CCG should have taken a lead role in that, which points to failings in multi-agency working. So no surprise, that was an interconnecting theme in 42 reviews that I analysed, which links the failings in the components of assessments and the delays in service provision. William was considered fit for discharge in May 2016, but didn't transfer to that specialist placement until August. So all that time, he was detained in hospital. The review acknowledged that multiple placements declined to accommodate William, which led to a prolonged search because of the challenging behaviour, but there were still failings because the CCG didn't participate in the process to secure accommodation. His eligibility under section 117 for the aftercare was identified in April. It had been validated by the CCG in May, but it wasn't until August that the CCG and the local authority confirmed funding for the new placement. A need for clarity regarding funding responsibilities was also highlighted as a recommendation in a SAR involving Danny, which was undertaken by Gloucestershire Safeguarding Adults Board. That made numerous recommendations, including training for mental health trust staff regarding application of the CPA approach and incorporating that monitoring of section 117. Training was the most prevalent theme in regards to recommendations, featuring in 36 SARs, 51%. Legal literacy and use and application of the Mental Health Act were the most common cross-cutting themes, and the majority of those were multi-agency recommendations. In addition, the need for a multi-agency section 117 policy was identified to include eligibility, review, discharge and funding arrangements. And the review recommended that the CCG allocate section 117 discharges to a case manager to undertake that liaison with the local authority to jointly identify and commission services, because that would ensure clarity regarding roles, responsibilities and pathways for the patient care. Hampshire SAB undertook a SAR in respect of Sasha. She was in receipt of services and subject to section 3 of the Mental Health Act when she died. Like William, during the period under review, she'd been detained under section 2 and section 3. She was discharged from hospital on occasion when she was detained under the Mental Health Act, and services were not always aware of her Mental Health Act status. So again, that's mirroring those themes from the Williams SAR. Because they weren't always aware of that status, they didn't always act in accordance with the legislative requirements. It was clear that good practice was intended by professionals, and I'm sure that's the case in all the SARs we see. Nobody sets out to do a good job, to not do a good job. We all set out to make life better for the people that we're working with. So it was clear that professionals had attempted to implement the Mental Health Act in accordance with Sasha's best interests, intersecting with Principle 4 of the Mental Capacity Act, but the application of legislation wasn't compliant with the provisions as specified in the Act. So again, like we've seen with William. Training, again, was the most common recommendation, with the use and application of the Mental Health Act and legal literacy the most common categories of training that were referred to. The majority of those were multi-agency, but NHS trusts and adult social care departments were the agencies most commonly directed to commission training or improve the training offered. It's recognised that the relationship between the Mental Health Act and other intersecting statutes is complex. So, for example, the Mental Capacity Act, the Human Rights Act, the Care Act, the United Nations Convention on the Rights of Persons with Disabilities. The fact that the existence of a disability shall in no case justify deprivation of liberty, that's Article 14 of the UNCRPD, that's at odds with detention due to the existence of a mental disorder. So where an individual is detained under the Mental Health Act, physical health care can only be administered if it's part of the treatment for that person's mental disorder. So that's under Section 3. Treatment for physical disorders is outside of the remit of the Mental Health Act and can only be given in the absence of consent if it can be justified under the Mental Capacity Act as being in the person's best interest. So we can see all these intersecting statutes that are working together and sometimes they're fighting against one another. A case example is B and Croydon Health Authority, which goes back to 1995, but we find that often cases that have then become case law are from quite a while ago. In that case, the court interpreted medical treatment to include secondary functions, including nursing and care, concurrent with core treatment, or as a necessary prerequisite to such treatment, or to prevent the patient from causing harm to himself. The law always diverts to the male, or to alleviate the consequences of the disorder. So going back to the case of Sasha, she wasn't treated according to the law in response to her self-harm. The review highlighted inconsistencies in the manner in which the Mental Capacity Act was applied and the Mental Health Act assessments were recorded. It had been recorded that Sasha sometimes had capacity to refuse treatment, but that shouldn't have given rise to her being allowed to leave the hospital because she was subject to the detention under Section 3. The review acknowledged that case law concerning that principle of the Mental Health Act and the intersection with the Mental Capacity Act can be problematic, and individual cases should be evaluated on their own merits. So another case example is Nottinghamshire Healthcare, NHS Trust and RC, which is a bit more recent, 2014. That case highlighted the tension that exists between legal provision and the parallels between the Mental Health Act, Section 63 of the Mental Health Act, and the Mental Capacity Act. And because of that, the difficulties which might then manifest in practice. So in that case, the court held that it was lawful not to use the Section 63 power, which is treatment not requiring consent, compulsorily to treat a self-harming Jehovah's Witness who'd made a valid and applicable advance decision to refuse treatment. Going back to Sasha, she had made an advance decision, but contrary to the Nottinghamshire Healthcare Trust case, it wasn't binding. So in the Nottinghamshire case, that advance decision was binding, Sasha's wasn't. And the outcome of the case was that specialist legal advice would have been beneficial in the case of Sasha, because it would have provided that expertise to the health and social care professionals. The review acknowledged they were working within a very complicated area of the law. Additionally, the review identified that professionals may have undertaken the capacity assessment differently had it been acknowledged that Sasha had a diagnosis of autism spectrum disorder. 3 further SARs made recommendations in respect of supporting people with autism, including that services are designed and delivered in accordance with the structure, positive approaches and expectations, empathy, low arousal, links principles from the National Autistic Society. So there's a SAR called A from Bedford's Safeguarding Adults Board, which focused on autism and all those recommendations from the National Autistic Society. I mean, it seemed to me really undertaking this research that people perhaps weren't taking the messages about recommendations for practice from earlier SARS because they could have been applied to practice to maybe stop some of these things happening. Delays or reduction in service provision was a commonality in 26 SARS, and as stated in the Mental Health Act Code of Practice, and we've already touched on this, it's the responsibility of the CCG, as it was at the time, to ensure sufficient numbers of beds and availability of Section 12 doctors to meet the needs of the population. Section 12 doctors are registered medical practitioners approved under Section 12(2) as having special experience in diagnosis or treatment of mental disorder to give one of the medical recommendations required for compulsory admission to hospital under the Mental Health Act. In addition to that, Section 140 of the Mental Health Act, set out in the Code of Practice, outlines that health duty, so again it was CCGs at the time, to notify local authorities regarding special cases or emergency admissions. The reviews analysed identified there were often difficulties accessing Section 12 doctors when arranging those Mental Health Act assessments. And that was evident in a unique case of Mrs. B.A., who required admission and treatment under the Mental Health Act. This was an unusual case for a safeguarding adult review because no abuse or neglect had been identified prior to her death. But Bexley SAB that undertook the review concurred that her death was a result of suicide and it met the criteria for a SAR under Section 44 of the Care Act. The SAR centred around treatment in respect of her mental health, care for her children and immigration status, and acknowledged the complexities of the case because it spanned adult mental health and children's social care. There were child protection concerns. BA's husband expressed appreciation for support that had been provided by services, but he articulated his disappointment when the support ceased, and that was due to service reorganisation. So there was nothing to say that her needs had changed. The service was reorganised and then she wasn't getting the service that she had been getting. There were frequent delays in Mrs. B.A. being admitted to hospital, and admission usually followed a mental health crisis. Her husband discussed that earlier involvement of services may have prevented the crises from occurring at all. Additionally, her husband explained that she was often discharged too soon, which resulted in a rapid readmission because she remained unwell. He recalls an incident where she was in crisis, and despite him being on the telephone to the 24-hour emergency line for an hour, his call wasn't answered. She absconded twice during the same period of detention in 2016, and the Safeguarding Adults Review noted a lack of beds, which resulted in her not being readmitted on the first occasion. Consequently, she was placed in a private psychiatric unit as her local trust didn't commission female intensive care beds. Utilisation of private provision may result in negative experiences for individuals on discharge back to the local mental health services, and the King's Fund undertook some research in 2015, which was all around the use of private provision and the experiences of individuals. The accompanying lack of local beds caused Mrs. B.A. to be discharged home while she was acutely unwell, proving that hypothesis that the private provision had led to a negative experience. It also coincided with inadequate handover to local services. A lack of local services is interconnected with difficulties caring for individuals who are experiencing mental health crisis, which increased risks to them and to their families. And sadly, this was certainly the case for Mrs. B.A., as her husband highlighted the fact that attempted access to the crisis line was unsuccessful. That increased the risk of carer breakdown and in turn the risks to Mrs. B.A. associated with her being in crisis and without the appropriate support. The review acknowledged that a shortage of local services was not unique to her case. The Care Quality Commission undertook a national report on mental health services, which was published in tandem with Mrs. BA's review, and that emphasised that a lack of local services was a significant area of concern. That was a report published by the CQC in 2018. Notwithstanding, the review did note that improvements had been made after Mrs. BA's death, as the local trust had contracted 12 further inpatient beds. The most recent CQC inspection report at the time I did this research had rated the service as good, noting that most people were able to access services when needed and that waiting time targets for assessment and treatment were met. That was a report from 2019. Areas of good practice were identified throughout the analysis. So notably, it was professionals upholding human rights. And a good example of that was Miss T, and that was a review undertaken by the Isle of Wight SAB. It illustrates how professionals kept Miss T at the centre of Mental Health Act assessments and safeguarding practice. Miss T had encountered adverse childhood experiences. That was a commonality identified in 22 reviews, although only featured as a specific recommendation in 3 cases. She used drugs as a means of circumventing traumatic memories and had rudimentary contact with substance misuse services. 27 SARS featured individuals who were misusing substances. The majority of those were drug and alcohol use. 5 SARS made specific recommendations concerning substance misuse, with a cross-cutting theme of training, which should take account of the impact of illicit drug and alcohol use. That was in the SAR for N, commissioned by Bexley SAB, or that organisations' drug and alcohol training offers should be reviewed. That was Grace, and Grace's SAR was undertaken by Merseyside. Miss T's views and wishes were central to the safeguarding process, with professionals exploring effective and sensitive ways to support her. She was assessed under the Mental Health Act, with professionals comprehensively considering the guidance and the legal principles of the Act. Ethical and legal complexities were evaluated. For example, the fact that application for detention in her best interests would be inappropriate because her mental disorder wasn't assessed as being such to warrant detention at that time. The consideration of the intersection between the legislative principles of the Mental Capacity Act and the guidance set out in the Mental Health Act Code of Practice clearly demonstrates that Miss T's human rights were considered in conjunction with a proper acknowledgement of the risks. She was detained under Section 2. Her human rights were upheld throughout. There was a referral for an independent mental health advocate, and that was to empower her to understand and to exercise her legal rights. There were also some other good practice examples, but time prevents us from going through them all today. This just looks at the main themes really from the Ruth Mitchell case, which was undertaken by Plymouth SAB, but we'll go on to the domestic homicide reviews now, as the slides will be circulated. So under Section 9(1) of the Domestic Violence, Crime and Victims Act 2004, a domestic homicide review means a review of the circumstances in which the death of a person aged 16 or over has or appears to have resulted from violence, abuse or neglect, either by a person to whom they were related or had been in an intimate personal relationship, or a person that was in the same household. And like safeguarding adult reviews, the aim is not to apportion blame, it's to identify lessons to be learned. So the purpose is to establish what lessons are to be learned regarding the way in which professionals and organisations work individually and together to safeguard victims, to clearly identify what those lessons are within and between agencies, how and within what timescales they'll be acted on, and importantly, what is expected to change as a result, and to apply those lessons to service responses, so how national and local policies and procedures will change as a result of that domestic homicide review. to prevent domestic violence and homicide and improve service responses for all domestic violence and abuse victims and children by developing a coordinated multi-agency approach to ensure that domestic abuse is identified and responded to effectively at the earliest opportunity, to contribute to a better understanding of the nature of domestic violence and abuse, and to highlight good practice. And I think quite often we lose good practice because we hear so many negative things and things that had gone wrong, which is really why I wanted to give that good practice example a couple of slides ago. I'm going to focus on looking at domestic homicide reviews where there was victim suicide. So it still feels quite new, but it was back in 2016 that the UK Home Office updated their guidance for community safety partnerships to include domestic homicide reviews where a victim took their own life and the circumstances that give rise to concern. So, for example, it emerged that there was coercive or controlling behaviour in the relationship. I think this bit is really important and links in with those safeguarding principles of making safeguarding personal, that the guidance stresses that DHRs need to be written through the eyes of the victim. So taking that holistic approach to the review and being professionally curious. So we've said lack of professional curiosity is a recurrent theme in SAR recommendations. And whilst the police have a vital role to play in domestic homicide reviews and domestic abuse, the police alone can't identify and safeguard all potential victims and suspects of domestic homicide or victim suicide. We know the police are doing a cracking job. They're constrained with resources, like I think everybody in the public sector is, and this is why it is most important that we all work together, all the agencies work together to identify and safeguard the victims or people that are suspected as being at risk of domestic homicide or victim suicide. The most recent national analysis of DHRs shows that both victims and suspects were known to agencies other than the police. So again, we are saying it is not just the responsibility of the police. And I think really it's that message that safeguarding is everybody's business. It equally applies to DHRs. They are equally a safeguarding mechanism. In a number of cases, the suspects or the victims in the adult family homicide cases and suspected victim suicide cases were known to mental health services. So again, it mirrors the SARS that we've just looked at. The findings highlight the importance of agencies working together. So the UK Home Office confirmed in August this year, so pretty recently, that the number of DHRs involving the suicide of victims of domestic abuse had increased significantly. And again, this is just what we know, what's been recorded. There'll be cases where there hasn't been a DHR, where services don't know about the person. So it is really greater than what we know. In 2021, the Home Office received 173 notifications of a DHR having been commissioned, and 25 of those were suicides. And then if we look at 2022, there were 192 notifications, 44 of which were suicide. So there's not been a huge jump in the numbers of DHRs, but if we look at the number of suicides, you know, it's like another third again. The review just looked up to January this year. So in those 6 months, January to July, or 7 months, I should say, there'd already been 128 notifications, 36 were suicides. So I think we can say with a fair degree of confidence that when we've got all the figures for 2023, there's going to be more notifications and there are going to be a lot more suicides when we compare with 2022 and back to 2021. Victim suicide was the third highest cause of death for DHRs between 2020 and 2021, which were COVID-19 pandemic years. Bates undertook some research as part of the National Policing Vulnerability Knowledge and Practice Programme and found that there wasn't a substantial increase in the number of DHRs during the pandemic, although acknowledged that domestic abuse and linked suicides remain a significant concern. So looking at some statistics, I am a fan of stats, so apologies if you're not. In 90% of the DHRs involving victim suicides, the victim was female. In 72% of those DHRs that involved victim suicides, the victim was aged under 45, 91% of suspects were male. The proportion previously referred to MARAC was similarly high in both intimate partner and suspected victim suicide cases. So we're not yet seeing any trends around that where there are victim suicides, but the research in this area is still quite new. Black, Asian and minority ethnic groups accounted for the smallest proportion of DHRs involving victim suicides, but the greatest proportion of child deaths and adult family homicides during the pandemic. That might possibly indicate under-identification of suspected victim suicides against minoritized ethnic groups. So I think that more research will need to be done around that. Previous non-fatal strangulation by the suspect of this or a previous victim was more prevalent amongst DHRs involving victim suicides. Coercive control was the most prominent case characteristic, and as with intimate partner homicide, attempted or actual separation was present in a sizable number of cases, so we know that that increases the risk. Research shows that women are less at risk of death by suicide than men. That's from the ONS figures from 2019, published in 2019. So that makes it particularly relevant that more women than men feature in this analysis. Professor Sylvia Walby undertook some research, and the link is there in the slide. She identified that 1 in 8 female suicides and suicide attempts in the UK are due to domestic abuse, which equates to 200 women taking their own lives and 10,000 attempting to do so. And that's just those that are due to domestic abuse, so not the wider picture. The research identifies the link between domestic abuse and suicide or suicidal ideation. Coercive and controlling behaviour is a substantial risk factor in both intimate partner homicide and suspected victim suicides where there is a history of domestic abuse. There's a new DARA risk assessment tool, the Domestic Abuse Risk Assessment, which has been shown to better identify coercive and controlling behaviour, and it's designed for frontline police practitioners who are responding to domestic abuse, which should focus on making it easier to identify coercive control so that responding officers can make better informed risk assessments. In July this year, 32 domestic homicide reviews involving victim suicide were analysed, and I analysed those to ascertain whether there were commonalities with the research that Bates had undertaken. Cases were identified through community safety partnership websites, and I think we're in a bit of a better position than SARS because the UK Home Office has now launched a domestic homicide review library. And if you just type into Google domestic homicide review library, it'll come straight up. Because I work in Cheshire, I'd concentrated sort of a Cheshire analysis, then a North West England, a nearest neighbour local authority, so they're those SIPFA nearest neighbours that are demographically similar to the Cheshire area, and then a national analysis. This was because in Cheshire, there have been, I think we've got 3, possibly now 4, ongoing DHRs that all involve victim suicide, which is, we've never had that before, and they've all come really at the same time. So we wanted to understand more about them. There weren't any themes around suicide in any of the other local authority areas in Cheshire, so it's only in Cheshire East that we know of at the moment, or that was certainly the case in July. Looking at North West England, there were 3 domestic homicide reviews involving victim suicide, mental health, suicide by hanging, issues of loss and separation featured in 2 cases. Female victims featured in all 3 of those cases, and drug or alcohol use featured in 2 cases. So the nearest neighbour local authority areas were Bath and North East Somerset, South Gloucestershire and Wiltshire. They were the areas where we'd got DHRs. 12 DHRs involving victim suicide were undertaken across those areas. There were female victims in 9 cases and suicide by hanging in 7 of those cases. Mental health featured in each case. Bipolar disorder featured in 3 cases and also featured in 1 case in Northwest England. 92%, so 11 of the 12 cases featured drug or alcohol use. Domestic abuse in the victim's parents' relationships featured in 2 cases, which we didn't see in any of the Northwest DHRs, but again, we'd only got 3 cases in the Northwest. Suicide of a parent featured in 2 cases. Suicide of a partner featured in 1 case. And that case also featured suicide of a parent. So significant trauma that that person had experienced. Sexual exploitation featured in 2 cases, and debt or economic abuse featured in half of the cases. Looking at other local authority areas in England, so that was the national analysis, there were 17 DHRs involving victim suicide. There could be more, but this is all I could find at the time I did the analysis back in July. 15 of those cases, 88%, involved female victims. 41%, 7 cases involved suicide by hanging. Mental health featured in 16 of the 17 cases, and drug or alcohol use featured in 13 cases. Domestic abuse in the victim's parents' relationship featured in 4 cases, and debt or economic abuse in 41 cases. And I think, okay, so Ruth Mitchell lived in Plymouth. The case was undertaken by Plymouth Safeguarding Adults Board, and she had a significant history of contact with services. A mental health assessment was undertaken in response to concerns that Ruth was behaving out of character, but she wasn't admitted to hospital and received follow-up in the community. 2 months after that assessment, she was admitted to psychiatric hospital, and on discharge, she received support from a social worker and a community psychiatric nurse. The nurse referred her to alcohol services, but she declined to engage. It's important to note she remained subject to CPA, the care programme approach, throughout, and a series of Mental Health Act assessments followed, with professionals and Ruth's parents, who were quite involved in Ruth's care, expressing concerns regarding her use of alcohol. In 2007, she requested discharge from mental health services, and her parents lodged a complaint in respect of the support provided to Ruth. They expressed concern regarding her isolation, the increasing use of alcohol, and the lack of communication from services. Less than a month after that complaint, she was actually discharged from CPA. She remained on standard care with the consultant psychiatrist as the lead professional, and she expressed that information regarding her mental health wasn't shared with her parents. Now, professionals knew that parents really concerned, they really cared about Ruth, they were concerned about her. So a process was initiated to provide reassurance to the parents while respecting Ruth's right to confidentiality. So that was good practice. And a professional who Ruth had known previously was introduced to support that relationship between Ruth and her psychiatrist. So the professional would meet Ruth at outpatient appointments and then brief Ruth's parents regarding her attendance. So they wouldn't divulge any information, they'd just say, yes, Ruth's attended, and they just give sort of basic information to say, yes, she looked okay. When the professional left the team the following year, no arrangements were made for anybody else to undertake the role, so her attendance at appointments became sporadic, and risk assessment had formed part of each outpatient appointment until risks stopped being recorded in 2010. So after the CPA ended and she was just under the care of the consultant, risk evaluation was based on her self-reports. So Ruth said she'd stopped drinking, and the risk rating for alcohol was then excluded from assessment. So what she said was taken at face value. However, not long after that, Ruth was refused access to an outpatient appointment because she was intoxicated. Her engagement declined, and professionals acknowledged that her engagement was poor. The psychiatrist's perception was there were no serious risks of harm to herself or to others that would warrant a more significant response. The psychiatrist recorded that an over-intrusive approach would result in progressed disengagement, and the review had noted that professionals said Ruth was well presented, whether she was well or unwell, and those assumptions appear to be based on Ruth's own perceptions as what she could do, as opposed to any framework of formal assessment. So more than 2 years before Ruth died, there were concerns about a lack of engagement, but the corresponding professional opinion was over-intrusion into Ruth's life was likely to result in disengagement. So that disengagement was just accepted by professionals. A significant aspect of learning from that review was an examination of how assessments can identify self-neglect, and it noted that professionals should seek to understand how negative symptoms of mental illness impact on individuals' engagement with services. So the risk of non-engagement is actually an indicator for a person reverting back to CPA. And the CPA guidance states that health professionals should consider substance misuse, specifically when that coexists with mental illness, in deciding whether a person requires support under CPA. So 52 of those SARS that I analysed had that theme of failing to undertake assessments or inadequate assessment, reflecting those wider recommendations from thematic reviews. So that reflected what Michael Preston Shute had found. 91% of SARS found that risk assessment accuracy. Again, that mirrors what Preston Shute found in 2016 and reflected recommendations from a number of SARS. So we've already spoken about Ruth Mitchell, and Bristol SAB undertook a SAR called Carmel Ahmed and Mr. X, and that looks at risk assessments lacking accuracy. And we said at the start about that 2016 that Aylett looked at the serious case reviews, and again he'd said that reviews are used to strengthen the scope of learning among professionals. So those commonalities are better coordination of multi-agency assessments, confirming my findings and findings of Preston Shute and Martineau and Manthorpe and Martineau in 2019. They had identified that an absence of or a deficient risk assessment was an overarching theme in their review of SARS that referenced mental health legislation, a lack of multi-agency working, and CPA practices that were not aligned with the inclusion criteria. So it's absolutely mirroring the Ruth Mitchell case. I'm sure a lot of you will have heard of Susie Bray, and as far back as 2013, so 10 years ago, Susie Bray noted that training only goes so far, and a supportive professional environment tends to result in improved practitioner understanding. That Southwest review that Preston Shute did in 2017, 64% of those reviews highlighted poor recording, inadequate detail in assessments, and the content of assessment often separated from the decision-making, which meant that people who were eligible were not accessing services under Section 117. So again, this is absolutely mirroring what we found out in the Ruth Mitchell case and in the earlier cases we'd looked at where people were not getting that support they were entitled to under Section 117. So I suppose to conclude, the findings of Preston Shute in that Southwest review, which was a very large thematic review, the conclusions from the serious case reviews that Aylett published in 2016, and then the findings from Martineau, which were more recent, 2019, they found that agencies didn't work collaboratively, reflecting missed opportunities. A good example of that is the SAR for A, which was undertaken by Bedford Safeguarding Adultery Board, and collaboration was highlighted recommendations from 9 SARs, which referenced a need for agencies to work more closely together with a shared approach to managing risk. And a good SAR to look up if you want to find out more about that is a SAR from Kenton Medway in respect of Charlotte Burton. So I think I've probably spoken enough now, and I'm happy to take questions if anybody has anything.
Just before we go to questions, Debbie, I just wanted to say thank you for that on behalf of Partners in Care for National Safeguarding Adults Week. And I think it is good to end on a situation that evidences that learning is the really key purpose of carrying out safeguarding adult reviews in DHRs.